Hi, I'm Adam Devore, and I'm joined today by Dr. Marc Sabatine, the director of the TIMI Study Group and professor of medicine at Harvard Medical School. Thank you, Dr. Sabatine.
Adam, thanks for having me.
So today we're going to talk about what everyone's talking about here at ACC, the PEGASUS trial. Congratulations on completing the trial, and I was wondering if you could provide us with a quick overview of the trial or the background before we get into the results.
Sure. Well, as you know, when patients come in with a myocardial infarction, we treat them with dual antiplatelet therapy. We treat them with aspirin, and we also treat them with the P2Y12 inhibitor. The aspirin we continue lifelong. The P2Y12 inhibitor we stop after 1 year of therapy. That's really just because the trials that had previously studied them were 1 year in duration. But we had intriguing clues from those trials where the event curves appeared to continue to separate out over time, suggesting that more prolonged therapy with a P2Y12 inhibitor might result in better long-term outcomes. That was the basis for PEGASUS TIMI 54, where we enrolled patients with a history of MI, in this case 1 to 3 years prior, and then randomized them to one of 3 different arms, either to get ticagrelor 90 milligrams twice daily, that's the dose that was studied and approved in ACS, or ticagrelor 60 milligrams twice daily, that based on modeling should achieve slightly lesser degree of platelet inhibition but still quite robust and quite consistent, or to placebo. In addition, all patients were to be on low-dose aspirin therapy and standard of care for post-MI patients. And so we enrolled over 21,000 patients. The median follow-up was close to 3 years, and we found that treatment with ticagrelor, both doses, reduced the risk of cardiovascular death, MI, or stroke. For the 90 milligram dose, it reduced it by 15%. For the 60 milligram dose, by 16%, both highly statistically significant.
That's great. And I was wondering if you could expand a little bit more on the 2 doses. When you were planning the trial, what was really driving you to consider both doses in your trial design? And then second, if you could comment on why you didn't see a dose response in terms of efficacy there.
Yeah, so it's a very good question. I think the notion is that the amount of platelet inhibition a patient may need 2 years after their MI may be different than what they need 2 hours into their MI. And so that's why we wanted to study 2 different doses. Even though the milligrams seem quite different, 90 and 60, at least in the modeling, the difference for platelet inhibition isn't that great, probably on the order we would have suspected on 10 to 15% or so. However, we do have a dedicated pharmacokinetics and pharmacodynamics study that Rob Story led, and we hope to present those results at an upcoming meeting. But that, I think, will be very important to help put the 2 different doses in pharmacologic context.
Well, that's great. So what are your advice moving forward for practicing clinicians out there in terms of how will this change practice?
So I would say for your patient coming in with an acute myocardial infarction, per the guidelines, I treat them with aspirin and ticagrelor, and then at the 1 year mark, keep going with both.
Sounds great. Thanks again for your time. And for more updates from ACC, please follow us at the Duke Fellows blog.